This is Medication Safety CE. So, Lauren, the floor is yours. Thank you very much.
Alrighty, thank you, Ken. So again, my name is Lauren, and I am a PGY1 at the Buffalo VA. And today we are going over the 2023 Beers Criteria Update, and this presentation is called Age to Perfection. So just to start, I do not have anything to disclose or any conflicts of interest related to this presentation. So the purpose of this presentation is to equip pharmacists with the comprehensive knowledge and skills related to Beers criteria for potentially inappropriate medication use in older adults. This program aims to empower pharmacists to play a pivotal role in optimizing patient outcomes by providing evidence-based information on the pharmacological treatments options for older adults. This is going to include drug selection, patient education, monitoring, and deprescribing practices. This program strives to enhance pharmacists' proficiency in managing medications while highlighting new advances to guideline updates. So at the end of this presentation, I would like you to be able to describe two highlights from the 2023 update to the Brewery's criteria for potentially inappropriate medication use in older adults. Give one example on how to use the 2023 Brewery's criteria list in clinical decision making. Identify two commonly used medications that should be avoided in the elderly. Name two tools that will assist with deprescribing, and describes one example where the following Beers criteria can prevent a medication error, aka the wrong drug, the wrong dose, or the wrong route. For pharmacy technicians, I would like you to be able to identify highlights from the 2023 update for the Beers criteria of potentially inappropriate medication use in older adults. Identify commonly used medications that should be avoided in the elderly. List 5 medication classes that could be increase the risk of falls, and discuss one example where the following Beers criteria can prevent a medication error, again, the wrong drug, the wrong dose, or the wrong route. So I'm sure you guys have all seen this before, and if you haven't, this is the beginning of the Beers criteria. So the Beers criteria was first introduced in 1991, and they are updated periodically. It's usually every 3 years. The most recent update was in the 2023 guidelines, and this replaced the previous version that was available in 2019. So the criteria itself is organized into 5 categories and developed by an interprofessional expert panel. So the 5 categories are medications considered potentially inappropriate, medications potentially inappropriate in patients with certain diseases or syndromes, medications that should be used with caution, and potentially inappropriate drug-drug interactions, and medications with dose adjustments based on renal function. So really, these are a set of guidelines and recommendations aimed at improving the appropriate use of medications in adults, defined as those greater than the age of 65 or older, as elderly patients have a unique physiological changes and increased susceptibility to adverse drug reactions. This is specialized for considerations when prescribing medications. Age-related changes in the body composition as well as organ function can influence the pharmacodynamics and pharmacokinetics of many drugs, which is why we really want to look into the Beers criteria today. So just to go over some basic statistics, an estimated 80% of older adults in America live with at least one chronic condition, and more than 50% of those older adults have been diagnosed with 5 or more chronic conditions. In addition, older adults, including older veterans, have had increased susceptibility to morbidity and mortality related to adverse drug events, and these are associated with age-related changes, comorbid chronic conditions, and different pharmacodynamics. So looking at the bigger picture, essentially everyone is aging, and there's been a shift in the age distribution in the United States. There was a recent 2022 CDC update where they said nearly 58 million adults ages 65 or older live in the US, and this accounts about 17.3% of our nation's population. And by 2040, it's only supposed to increase in population. So they said it's going to be about 22% of people in the US will be greater than age 65 in 2040. So then there are a couple changes that we have to consider when you get older. The first one is cardiovascular. So this one is where your heart wall thickens, your heart rate can decrease, and your systolic blood pressure can increase. In pulmonary system, we see the chest wall thicken and central airways widen, and this can decrease pulmonary function. In the central nervous system, the brain size and blood-brain barrier decreases. In the endocrine system, kidney size decreases and GFR decreases. In the hepatic system, the liver mass and CYP450 decreases. And in the immune system, you can see there's also a trend in decreases, so the entire immune system function decreases as well. In the GI tract, gastric emptying frequency decreases and gastric emptying time duration increases. So overall, the body water and muscle ratio decreases and the body fat increases. Which leads us to why the use of and understanding of Beer's criteria is so important. So polypharmacy is a particular concern for older adults as it increases the risk for drug-drug or drug-disease interactions, which can lead to adverse effects. So by raising potential inappropriate medications and promoting safer alternatives, the Beer's criteria plays a pivotal role in enhancing the quality of care and the overall well-being of older adults. So the goal is to optimize medication regimens, and that's a fundamental step towards minimizing exposure to adverse effects and improving the health outcomes in the elderly population. So just going over some basic definitions for the next two slides, because I'll be using these a lot throughout this presentation. So the first one is a big one in the Beers list. So what is a PIM? So it is a potentially inappropriate medication, or PIMS, and they're defined as medicines or medication classes in which the risk of AD adverse drug events usually outweigh the clinical benefit. So these medications should be avoided in most circumstances or for certain diseases or condition among older people. And then we just wanted to find some of the strength of recommendations that they listed in the new update. So the strength of recommendation rating for each criteria is based on the synthetic integration of a quality of evidence, the frequency and severity of potential adverse events, and their relationship to potential benefits and clinical judgment. So they kind of define it in two different parts, so it's either strong or weak. So the strong strength of recommendation, it is harms, adverse events, and risk clearly outweigh the benefit. Whereas weak, it has harms, adverse events, and risk may not outweigh the benefit. And with the quality of recommendation, there's also the quality of evidence. So the quality of evidence ratings for each criteria are based on synthetic assessment of two complementary approaches to evaluating the quality of evidence. So in this case, there's going to be three different ones. There's going to be the high quality of evidence, the moderate, and the low. So moving on to some key principles to properly using the Beers criteria before we jumped into the changes. So PIMS are potentially inappropriate, not definitely. So it is a case-by-case for every patient, and you just have to make sure you're patient-specific. Then you want to read the rationale and the recommendation statements, understand why the medications are included in the Beers criteria, identify PIMS and offer safer alternatives when they're appropriate, and the starting point for a comprehensive process of improving medication safety. And this also should access to medications should not be restricted by prior authorization or health insurance coverage policies. And this is only applicable in the US. It's not for every country. So what is the true purpose of the Beers criteria? They listed it as being able to identify potential inappropriate medications that should be avoided in older adults, and also to reduce adverse drug events and drug-related problems. So jumping right into the updates. So what is new to the 2023 updates? So the first thing is new medications were added. Previous recommendations changed based on updated evidence. Some medications were removed based on no or low use in the US and equity. So it is split up into a couple tables. So table 1 is kind of what we went over in the definitions. So it's just designation of quality of evidence and the strength of recommendations. But table 2 is really the meat and potatoes. So it is the potentially inappropriate medications, and that's where we're going to see most of our 2023 updates. Table 3 is potentially inappropriate medications due to drug-drug or drug syndrome interactions. Table 4 is medications that should be used with caution. Table 5 are potentially clinically important drug-drug interactions. Table 6 is medications that should be avoided or have dose reduced with varying levels of kidney function. Table 7 are the anticholinergic property drugs. And then tables 8, 9, and 10 are kind of all the updates, but tables 8 will have the drugs that were removed or the medications removed from this update. So moving on to table 2. So this is the largest table, and it's organized by organ system and therapeutic category. So this table, which focuses on PIMS in older adults, has the most revisions since the 2019 update, as I said in the last slide, and in particular, the changes made to the following medications and our drug classes. So in summary, this is what we're going to go over in the next few slides. Warfarin, aspirin, and rivaroxaban, dronedarone, digoxin, antidepressants, antipsychotics, benzodiazepines, androgens, systemic estrogen, sulfonylureas, and protein pump inhibitors, as well as oral NSAIDs and skeletal muscle relaxants are going to all be in the new updates. So starting with our first one, aspirin is a cornerstone of antiplatelet therapy for the secondary prevention of CVD, but its role in primary prevention remains uncertain. So I'm sure everyone remembers a big article that came out, I think, in 2022, and it was kind of how aspirin shouldn't be used in older adults for the use of primary prevention. So over the past couple of decades, there's been great interest to identify individuals who had clinical benefit of aspirin for the prevention of the first heart attack or stroke, which is the primary prevention, and that exceeds the risk of bleeding. So they added it to table 2, so it's just part of the PIMS. So it does have a risk of major bleeding that increases with age. The risk does outweigh the benefits, considering that evidence is high and strong, and there's less evidence regarding stopping in long-term users. Just to let you guys know, it is still indicated for secondary prevention, ASCVD prevention, but their recommendation is to avoid initiating for primary prevention in the US and consider deprescribing if it was used for primary prevention. So on to our second one, it is still in the cardiovascular and antithrombotic section. So warfarin was added to this list on this update. So it's warfarin for the use of non-valvular atrial fibrillation or venous thromboembolism, or VTE. So their rationale was that there was a higher risk of major bleeding, especially intracranial bleeding, and it had similar or lower effectiveness compared to other agents. So what was included in this one is DOAC should be initiated for anticoagulation instead of warfarin, unless they are contraindicated or substantial barriers exist. So what they recommended was to afford warfarin as initial therapy unless alternative options are contraindicated or there are substantial barriers. And they did note if they are on warfarin for long term before this update, it may be reasonable to continue if they are well-controlled INRs, which they define as greater than 70% of the time. And this one also had a high to strong quality of evidence and recommendation. And then continuing with the cardiovascular antithrombotics, they added rivaroxaban for long-term treatment of the non-valvular AFib or VTE. And the rationale for this one was it had higher risk of major bleeding and GI bleeding in older adults than the other DOACs, particularly when they looked at studies comparing it to apixaban. It is still appropriate if you want to consider it for once daily dosing, if that's necessary, if the patient would be more compliant that way or they can't take a twice daily apixaban. But they did note that all DOACs have a lower risk of intracranial hemorrhage than warfarin. So for their recommendation for Xarelto, it said avoid for long-term treatment of non-valvular AFib or VTE, as their safer anticoagulation alternatives are available, like apixaban and the other DOACs. And this one was a moderate to strong quality evidence and recommendation. So I just wanted to add a little summary slide because we're going to move past the cardiovascular antithrombotics. So they have different terms. So the first one is a use with caution recommendation, and this reflects less of a concern and less clear evidence than the complete avoid recommendation. So you do want to look at individual criteria on these medications just to make sure which one the patient would be best qualified for. And just to let you guys know, when selecting a DOAC, choosing a dosage, you have to pay special consideration to the kidney function, as you'll see in Table 6, which is the kidney function, indication, and their body weight. So with warfarin, they did say avoid, so that is the more recommendation of avoiding it completely and they just said avoid starting warfarin as initial therapy for treatment of VTE or the non-valvular atrial fibrillation, unless alternative options like the DOACs are contraindicated. And again, it just said that it can be considered to continue warfarin if their INRs have been well controlled in the past and they have no adverse effects. And then for Xarelto, this one was also an avoid for long-term treatment as there's safer alternatives like the other DOACs. And for dabigatran, this one is said use in caution. So this one, the recommendation is less of a concern or less clear evidence. So they just said compared to other DOACs like apixaban for the long-term treatment of non-valvular AFib or VTE. Which leads us into cardiovascular. So this one is dronedarone. So this had a rationale of worse outcomes reported in patients who had permanent atrial fibrillation or severe recently decompensated heart failure. So what they added was a new language. So it added, in some circumstances, worse outcomes were reported in patients with HFrEF or a left EF of less than 35 who had milder symptoms. So NA or NYHA class 1 or 2. And what they recommended was to avoid impermanent AFib or severe recently decompensated heart failure, and to use in caution with patients with heart or HFrEF with less severe symptoms. So some alternatives you can consider to this medication is some of the safer ones like metoprolol, verapamil, diltiazem, and digoxin, which we'll see in the next slide. So digoxin was on here for heart failure. Its rationale is it had conflicting evidence regarding benefits versus harm, but most but not all of the evidence was in HFrEF. So there is stronger evidence for other medications as first-line therapy in reducing hospitalizations and mortality. And the higher doses, no additional benefit, and they can increase risk. So as you see in that recommendation, if you're going to use it for heart failure, they recommend you avoid using it in greater than 0.125 milligrams per day. So the added language used in caution when discontinuing patients in HFrEF. So they just recommended avoiding it as first-line therapy for heart failure, which had a quality evidence of low to strong. And if you wanted to use it for heart failure, because alternatives weren't an option, just making sure it's less than that mgs per day. And it had a moderate to strong quality of evidence and strength of recommendation. So for this one, you just want to monitor DIG levels. Again, the goal is 0.2 to 0.8 for heart failure. You continue to monitor potassium, magnesium, calcium, and renal function if you're still going to use it. And then moving on to estrogens. So this is estrogen with or without progesterone, and it includes natural and synthetic estrogen preparations. So some of the evidence is the same. So evidence of carcinogenic potential, lack of cardioprotective effect, and cognitive protection. So what they added this year is for women who start hormone replacement therapy at greater than 60, the risks are greater than the benefits. It's linked to a higher risk of heart disease, stroke, blood clots, and dementia. This year they updated it and they did not recommend systemic estrogen to be initiated. So these are going to be the oral tablets or the transdermal patches. And if they are on it, they wanted you to consider prescribing if using this medication. So this had high or strong evidence for oral and patches. So it would be acceptable to use the lower dose intravaginal estrogen, like the cream or the tablets, for any kind of those managements of recurrent UTIs or other vaginal symptoms. And then this one was the first one in the diabetes category, the sulfonylureas, and this included all of them. So before it was just the longer acting ones, but now it's including all, including the short and the longer acting. So there is a higher risk of cardiovascular events, all-cause mortality, and hypoglycemia. It can increase the risk of cardiovascular death and ischemic stroke. So they did say long-acting agents are higher risk of prolonged hypoglycemia than the short-acting agents, but their recommendation was to avoid as first or second line monotherapy or add-on therapy unless there are substantial barriers to the use of safer or effective agents. And if it would be used, they would recommend the shorter acting agents like glipizide. So for the CV events and all-cause mortality, it had a moderate to strong recommendation, and the CV death and ischemic stroke was a low to strong. So really what they say is consider any other diabetic medication for this instead of adding this on. But if you do have to, they do recommend the glipizide. Which leads us on to probably the most common one that everyone sees. So they added a couple things to the proton pump inhibitors. So the risk of C. diff, bone loss, and fractures were all there before, but they added pneumonia and GI malignancies to the 2023 updates. And they just put avoid for use greater than greater than 8 weeks long, unless a patient is considered high risk, like if they're on corticosteroids or chronic NSAID use, if they have Barrett's, or they have the hypersecretory condition, or they need maintenance treatment. So the quality evidence for the C. diff, bone loss, and fracture was high to strong, and the moderate to strong was a new update, which was the pneumonia and GI malignancies. And some alternatives you can consider instead of using PPIs would be the H2RAs like famotidine, but keep in mind you would have to reduce the dose in poor renal function.
Oh, so that's
And then moving on to Beer's criteria, the antihistamine section. So this one, the first generation antihistamines are all listed below, but A added new language which said cumulative exposure to anticholinergic drugs leads to increased risk of falls, delirium, and dementia. So they want to consider anticholinergic burden and be cautious in the young old as well as the old patients. So everything else stayed the same. It was avoid with moderate to strong quality evidence and strength of recommendation. So then it moves on to antipsychotics. So typical and atypical were included in this class. It had a rationale to increase risk of stroke and a greater risk of cognitive decline, increased mortality and dementia in patients. So what was new in this update was association of increased risk between antipsychotic medications and mortality independent of dementia. If used, periodic deprescribing should be considered to assess ongoing need or the lowest effective dose. So for the recommendation, it has stayed the same, but it was avoid except in FDA-approved indications such as schizophrenia, bipolar disorder, Parkinson's disease, psychosis, adjunctive treatment to major depressive disorder, or short-term use as an antiemetic. And this one had a moderate to strong quality of evidence. So some alternative methods to consider that they recommended were some non-pharm behavioral interventions. So for our next category, it was the NSAIDs. So they are the non-COX-2 selective NSAIDs. And for this one, the rationale was increased risk of GI bleed or peptic ulcer disease in high-risk groups, including those greater than 75 years old or taking oral parenteral corticosteroids, anticoags, or antiplatelet agents. So the use of PPI or misoprostol reduces risk, but it does not eliminate the risk. So they recommend to avoid chronic use unless other alternatives are not effective and the patient can take gastroprotective agents. So they also said to avoid short-term scheduled use in combination with those oral parenteral corticosteroids, anticoags, or antiplatelet agents. And just one note, NSAIDs can also increase blood pressure and induce kidney injury, and the risks are dose-related, so they do just recommend avoiding it if you're going to start them. But some alternatives are some non-pharm interventions or Celebrex. Tylenol is a good option, as well as the topical agents as well. So for muscle relaxants, they added this criteria does not apply if used for spasticity, like baclofen and tizazidine, although these drugs can also have adverse drug effects. But the rationale for most of them are they poorly tolerated anticholinergic adverse effects, sedation, and increased risk of fractures, and effectiveness at doses tolerated by older adults is questionable. So what they recommend is to avoid, and the quality of evidence and strength of recommendation was moderate to strong. So moving on to our next table. So this is table 3, and table 3 contains information regarding PIMS that could exacerbate certain diseases or syndromes. There were less changes to this section of the recommendations, but they did add language changes, major additions, including dextromorphan, quinidine to the list of drugs to be avoided, as well as adding opioids and anticholinergics to this list. So starting with the first one, we have heart failure and dextromorphan and quinidine. So they do say avoid this because of the concerns of QT prolongation. And it did have a low but strong recommendation. And then the next one was the delirium and opioids. So they added opioids as one to avoid in patients who have delirium because there is an association between opioids administration and the delirium. For pain, they recommend using a balanced approach, use pain assessment tools and multimodal strategies that include non-drug approaches to minimize opioid use, and they recommended avoiding this combination overall. Which leads us to our next one. So this is histories of fall of fractures. So they just added new language to the anticholinergics. They were already in here, but they also have anticonvulsants, antipsychotics, benzodiazepines, the non-benzodiazepines, hypnotics, antidepressants that include TCAs, SSRIs, SNRIs, and opioids. So they may cause ataxia, impaired psychomotor functions, syncope, and additional falls. For the antidepressant selected classes, there was evidence that there is mixed or newer evidence that can suggest SNRIs may increase fall risk as well. And if one of the drugs should be used, consider reducing the use of other CNS active medications and implement other strategies to reduce falls. So what they recommended was to avoid unless safer alternatives are not available, avoid anticonvulsants except for seizures and mood disorders, avoid opioids except for pain management due to severe acute pain. So they had a strong, moderate recommendation for the antidepressants and opioids, and all others had a high and strong recommendation. So for table number 4, this is medications or PIMs to be used with caution. So in the most recent edition, aspirin and rivaroxaban were moved from table 4 to table 2, and Brilinta and SGL2 or T2 inhibitors were added to the table. So considerations for the using lower doses of Prasugrel were added into this, as well as increased risk of hyperkalemia with ARNIs, and additional changes were updated to clarify language that allow for better readability in this table. So as I said, they moved aspirin to table 2 as well as that Xarelto. So what's still on here is dabigatran, which is increased risk of GI bleed versus warfarin, or apixaban. And it is a use with caution in selecting the treatment for VTE or AFib over other DOACs. And then for Brilinta, so it did have that increased risk of major bleeding compared to clopidogrel, especially in patients greater than 75 years old, and the risk may offset the cardiovascular benefit in select patients. So with Prasugrel, they did add a dosing recommendation. So if you are using Prasugrel, consider lower doses, the 5 milligram dose, for patients greater than 75. And they changed out, it was a moderate recommendation before, and now it is moderate strong. And then continuing with table 4, so the first one, we already went over dextromorphan, quinidine, but they did add new language saying concerns with use of heart failure just because it was added to the disease interaction with the heart failure, and it was a use with caution. So with Bactrim, it can cause increased hyperkalemia, and before it just had ACEs, ARBs, and they added ARNIs with this update in patients with a reduced creatinine clearance. And then for sodium glucose cotransporters inhibitors, they added these completely, so everything is new. So it did have increased risk of urogenital infections and euglycemic DKA. So they recommend to use a caution and monitor for urogenital infections plus ketoacidosis. And this quality evidence and strength of recommendation were moderate with weak strength of recommendation. So for table 5, this is potentially clinically inappropriate or important drug-drug interactions. So for this update, the panel worked to clarify and consolidate the clinically important drug-drug interactions, most notably the use of multiple agents with anticholinergic activity, the concurrent use of greater than 3 CNS active drugs, and the addition of SSRIs to the list of warfarin drug-drug interactions was updated in this chart. So then starting with the first part, so before they added the RAS inhibitors, they were already included, the ACE-ARBs, and now they included ARNI, as well as potassium-sparing diuretics. And the recommendation for this one was to avoid use of more than 2 RAS inhibitors, or a RAS inhibitor and a potassium-sparing diuretic concurrently in CKD stage 3 or higher. For opioids, the interacting drug was with benzos, and it had a rationale that increased risk of overdose and adverse effects. For lithium, the interacting drug with this one was ACE, and then they added ARBs and ARNIs and loop diuretics. So this one can cause lithium toxicity. And then for warfarin, they added the SSRIs to it, but the interaction drugs stay the same with amiodarone, the Cipro, the macrolides, the ceftazithromycin, and Bactrim. So then we have some more drug-drug interactions. So for this one, they added the skeletal muscle relaxants, and the interacting drug was a combination of any of these and greater than 3 CNS active drugs. And for anticholinergic, they just added the delirium, falls, and fractures that we saw in the previous table. And just because anticholinergic do have some helpful links, it is important to just know the burden scales. So I just added a few options on here. So rank anticholinergic activity of drugs. We have a few options to help you assess the risk burden. So there's the anticholinergic drug scale, the risk scale, the cognitive burden scale, and the drug burden index. So there's been some studies showing the greater burden of anticholinergic and sedative medications to be associated with poorer function in older adults. There is worse performance on mobility and cognitive function testing, and this is not related to an overall number of medications with the use of anticholinergics or sedatives excluded. So it can lead to increased risk of falls and long-term care facility residents. And then moving on to Table 6. So Table 6 includes a list of agents needing dose adjustments based on renal function. So baclofen and NSAIDs were added to this table for this 2023 edition, and modifications were also made to sections for Bactrim and Xarelto, including a clarification of language and the rationale. So to start, we will start with Bactrim. So the Bactrim stayed at dose requirements of less than 30, but they added, especially with the use of an ACE-ARB or ARNI, and the recommendation was to reduce the dose if the creatinine clearance is between 15 and 29 and avoid if it's less than 15. For nitrofurantoin, they updated it to be less than 30, and the rationale was for pulmonary toxicity, hepatotoxicity, and peripheral neuropathy with long-term use. So it recommends to avoid in creatinine clearance of less than 30. And then for H2 blockers, they removed ranitidine just because it's no longer on the market for the US. They also removed apixaban, and they updated a few things to Xarelto. So Xarelto does have the reduced dose, and it's per the manufacturer-based indication. But in creatinine clearance of less than 15, they recommend to avoid it in general. Baclofen has a dose requirement or dose adjustment required for an eGFR less than 60 because it can cause encephalopathy. Recommend to avoid or use at the lowest dose and monitor the patient. And then NSAIDs were also updated. They're contraindicated if the creatinine clearance is less than 30 due to the risk of AKI and further decline in kidney function. So for tables 8, 9, and 10, it's basically all the updates that we previously mentioned. Table 8 we'll take a look at a little bit more because there's it's the medications that were removed, and this is just because they're either no longer in the US market or they weren't used a lot. Table 9 again is the additions, so everything we went over, and Table 10 is the modification or changes. So additional changes to the 2023 update had the removal of several medications from the main tables due to either low or zero usage in the United States. A total of 28 medications met this criteria, with 15 of them, or about half, removed due to low use, and 13 were removed because they were no longer available in the US. So of note, certain medications that met these criteria are still retained on the list, but by the group census or the panel that decided the updates, they decided that due to their over-the-counter availability and the likelihood that they're still being used, they just wanted to keep them on there. The updated guidelines noted that the removal of these agents from the main table should not be interpreted as a shift towards condoning the use of these agents. Rather, they just wanted to declutter it to make it a little bit easier for the everyday user to use. So it is important to keep in mind that the Beers list is a guideline and not every patient is going to fit into 100% of the criteria. It is important to look at patient specific when it comes to Beers list and deprescribing. The one thing we have to keep in mind is the biopsychosocial model when it comes to deprescribing, and as pharmacists, we tend to keep our minds in the biological section because that's usually the medication section, but goals of cares and open discussions are important as well. But I just wanted to go over a few tools that are helpful for deprescribing. So why deprescribe? So polypharmacy is a patient safety issue and affects increasing and significant portion of our population. Patients at risk for polypharmacy also have increased risk of adverse outcomes associated with the PIMS, and the potentially inappropriate medications include those that are not effective or not clinically relevant, not indicated, or they may even have a therapeutic duplication. So I just wanted to list some of the tools. So the ones that we bolded are the ones I'm going to go over today, but the stop-start criteria, the Beers list, Improve, Trim, Pill, the Canadian Deprescribing Network, Vione, and there's a lot of other tools that you can use for deprescription. But it is not a standard tool and it's not a mandate. Again, it's up to all patient specific and what the patient's goals of care is. The Beers criteria did update deprescribing in the 2023 update, and they added 2 links. They added the Canadian Deprescribing link in their criteria, as well as the deprescribing.org /resources link. So starting with Vione, so this is the vital life-saving medications. Are they important for quality of life? Optional for no major difference, not indicated or treatment complete, and every medication has a diagnosis or indication of use. So this is just a mnemonic for the Vione, and this is the one that the VA uses. So we do have the deprescribing dashboard. And the Viome program facilitates practical real-time interventions that can be tailored to various healthcare settings, organizational needs, and our available resources. So it actually implements CPRS, and this enables us to have the planned cessation of non-essential medications that are potentially harmful, inappropriate, not indicated, or not necessary. Here at our facility in the Buffalo VA, we tend to use this as a second check to make sure the PIMS are still appropriate for the medication or the patient, but it does provide us an easy way to make sure we are continuously having these goals of care discussions with our patients and their caregivers. So moving on to a quick overview of stop and start criteria. So this is a physiological system-based explicit set of criteria that attempts to define clinically important prescribing problems related to potentially inappropriate medications and potential prescribing omissions. So what it really is it's a graded system where the systems have, or the organ systems have different number of criteria met, but it does not include suggestions on how to discontinue these medications. So overall, it helps improve medication appropriateness, prevent drug events, and reduce drug costs for patients. And some big areas that a lot of people use it in are primary care, secondary care, and long-term care facilities. So then moving on to applications of key principles, it's important to remember these are motivation interviewing skills from school that when we learn them when it comes to deprescribing and medication-related events. So this is an open-ended conversation that can help us actively inquire about symptoms that could be adverse drug effects, as well as assess whether these could be related to medications. It is important to consider that drug-related harms may be greater in the frail old or the young old in people with multiple comorbidities. Lastly, we should consider risk of harm that results from multiple drugs given together. And are there any drug-drug interactions or even drug-disease interactions on the Beers list that we might be able to give guidance on when overall looking at deprescribing for patients? So I did just want to add some considerations. So for the Beers list and using Fione or Stop Start or any of those other helpful deprescribing tools, recommend deprescribing or consider deprescribing antipsychotics for the use of dementia. So Lexicomp actually, for most of these, had pretty good discontinuation methods, but just knowing each patient and going patient case by case. But for antipsychotics, they recommend decreasing the dose 25 to 50 every 1 to 2 weeks over a 3 to 6 month period in patients with dementia. For statins, they recommend you consider deprescribing for patients greater than the age of 80 for primary prevention, or if their life expectancy is less than 5. You would just stop the statin and there's no taper necessary. For proton pump inhibitors, which is probably the biggest one we see our older vets on here at Buffalo, we have a limited indications for long-term use is when you would consider deprescribing. And for this one, they did recommend gradually taper therapy until discontinuation to avoid worsening or rebound symptoms. So they either recommend going to a lower dose before discontinuing or going to a lower frequency from like BID to daily. And then from benzodiazepines like lorazepam, they recommend deprescribing for increased risk of confusion and falls, and it is not indicated for insomnia. So if it's for insomnia, to recommend deprescribing. And this one was also a taper, so it recommended decreasing by 25% every 2 weeks, then 12.5% reductions near the end of the taper if possible, and just recommending non-pharm treatments for the use of insomnia. And then we have some alternatives. So if you can discontinue the patient's Norco for pain or their cygobenzapine for muscle spasms, there's some alternatives. So things like acetaminophen, the topical creams, lidocaine patches, or even SNRIs. For glyburide and diabetes, they recommend the GLP-1 agonists or the DPP-4 inhibitors, SGLT2 inhibitors, but with caution. And if you do have to consider sulfonylurea, using a short-acting like glipizide is probably safer for the patient. And then we have paroxetine like for PTSD and anxiety. And alternatives could be other SSRIs or SNRIs like sertraline or venlafaxine. And even zolpidem for sleep. Insomnia, you can recommend melatonin for onset or sleep regulation, non-pharm treatment, Ramelteon, low-dose doxepin for maintenance. And then we also have some take-home points for deprescribing. So there are many tools and resources available to assess with both providers and patients when it comes to deprescribing. The successful deprescribing plans has to involve the entire team. So the providers, their caregivers, and the patients, especially in that decision-making process and what their goals of care are. And then when possible, using evidence-based guidelines, algorithms, and titration schedules to develop deprescribing plans. So in conclusion, the 2023 Beers criteria update included many changes. So the big ones that we went over today were the anticoagulation, diabetes, and the removal of infrequently used and unavailable medications. The success of Beers criteria depends on it being applied in a thoughtful manner, and using or utilizing these key principles and application strategies are intended to improve outcomes while minimizing unintended harms. So before I end today, we do have a couple pharmacist questions that we could jump right into. So for this one is a patient case, BW. He is an 85-year-old male who had a recent fall. So he has a past medical history of osteoarthritis, neuropathic pain, AFib, hypertension, HFpEF, diabetes, BPH, PTSD, anxiety, vitamin D deficiency, and recurrent falls. So his eGFR is 108 and his creatinine clearance is 100. So below is his medication list. So some notable ones, he's on Tylenol, he's on Norco, cyclobenzaprine, warfarin, Biscadile, vitamin D, zolpidem, simvastatin, tamsulosin, paroxetine, metformin, glyburide, and aspirin 81 for secondary prevention, as well as omeprazole. So the first question we have today is which of the medications are potentially inappropriate, and it is going to be a select all that apply. So I will get the poll going right now. It's just loading. Alrighty, and I could go back to the med list too, so you guys can see that. And then I'll just give it a couple seconds for people to respond. Alrighty, so it looks like everyone is getting the correct answer. So it is warfarin, glyburide, and omeprazole. So I did try to trick you guys with the secondary prevention of aspirin. It is only considered to avoid in primary prevention, but with the warfarin, the glyburide, and the omeprazole, they could all be considered for the deprescribing or potentially inappropriate medications. So then we have the answers right on the screen. So the next question, oops, little sneak peek, but it is what drug-drug interactions should be avoided? So we have paroxetine, hydrocodone, zolpidem, cyclobenzaprine. B is simvastatin, vitamin D3, Tylenol or warfarin, all of the above or none of the above. And I'll get that poll going right now. And then I'll just give it a couple seconds. Alrighty, it looks like everyone is going for this question quickly. So yep, the right answer was A, and it's just because with the new drug-drug interactions, they do recommend avoiding CNS depressants and greater than 3. So greater than 3 of these options, and these are 4 of them, or CNS active medications. So the next one is what changes could be made to BW's medications? And I'll get this poll going. Let's see. Again, I'll give it a couple seconds. Alrighty, and it looks like everyone is getting the answer correct. So it is all of the above. So you can consider warfarin to apixaban just because it is a safer anticoag. Again, we don't know what his INRs are, but if we can consider switching him to a DOAC, it would be safer just because of the bleed risk. If he doesn't qualify for omeprazole long-term use, it would be safer to DC it. And glyburide is an unsafe option just because it can cause a risk of hypoglycemia. And Jardiance with this HFpEF would be considered as an alternative. So then for the next section is going to be technician questions. So the first one are, which one is an anticoag or antiplatelet? And it's going to be select all that apply. And it looks like people are getting these ones pretty quickly as well. So we have apixaban, clopidogrel, and aspirin. And those are the correct answers. So then we'll go on to our next one, is which of the following is a benzodiazepine? And this one just have the risk of fall risk and delirium. So we'll launch this one now. And I'll just give it a couple seconds. And it looks like everyone is getting this one pretty quickly as well, and it is lorazepam. And then for our final question, it is going to be, which statement is true about how tamsulosin increases fall risk? So A, does tamsulosin have blood pressure lowering effects, which may cause dizziness and lightheadedness? Tamsulosin can induce CNS depression. Tamsulosin can cause tremors, or tamsulosin can lower blood pressure or lower blood sugar. So for this one, it is easy to remember that tamsulosin has the risk of orthostatic hypotension. And it looks like everyone is getting that one. Alrighty. So thank you guys all for listening. I'm willing to take any questions now. I do have my email on the screen just in case anyone wanted me to email them some of the beers or the deprescribing tools that the beers list, as well as some of the other ones I found. But thank you guys all for listening.
This was an excellent program. Thank you very much. I've posted the link to the survey. Very shortly, I'll be sending out the compounding CE invite for next week. Thank you. Have a nice weekend.
Thank you, you too.